And with that, we move to the final chapter for the post-op complications, which is devoted to fluids and electrolytes. And now I'm going to repeat some vignettes we'd already read, but this time our emphasis, our focus is going to be on the management. 8 hours after completion of a transsphenoidal hypophysectomy for a prolactinoma, a young woman becomes lethargic, confused, and eventually comatose. Review of the record shows that her urinary output since surgery has averaged 600 ml an hour, although her IV fluids are going in at 100. A serum sodium determination shows a concentration of 152. Remember, the normal is 140. So let me now start the review with a question. What is the meaning, when you read it on an exam question, what is the meaning of a higher than normal serum sodium concentration? And the answer is, in virtually every single case, it means the patient has lost water. You even have an idea how much, because every 3 milliequivalents per liter that value is above normal represents roughly 1 liter of water the patient has lost. So this serum sodium determination here tells you what you already had suspected clinically. This patient has lost water. This patient therefore looks dehydrated. But if that loss of water happens rapidly, as it did here over a few hours, the brain doesn't have a chance to adapt to that. The brain will be all shrunken and not functioning normally, and that's why this lady is in coma. But I have to point out that a virtually identical loss of fluid in terms of the volume, if it happens slowly, it enables the brain to adapt, and this is going to be important for the therapy. So let me read the next vignette to establish here a comparison. A group of Mexican nationals are smuggled into the United States in a closed metal truck. When the Border Patrol chases them, the smugglers abandon their chargers in the middle of the desert in the locked truck with no water to drink. The victims are found and rescued 5 days later. One of them is brought to your hospital awake and alert, with obvious clinical signs of dehydration and a serum sodium concentration of 155. The numbers suggest a similar problem. The vignette we read before is somebody who lost about 5 liters of water. This vignette we're reading now is somebody who lost about 5 liters of water. But vignette number 42, it happened over a few hours. A lady was in coma. In vignette number 43, it happened over 5 days, as the patient breathing, evaporating water from the lung got progressively dried out because he didn't have any water to drink, and his brain has adapted. And that's why, even though he looks dehydrated and he's pretty sick, he is awake and he's alert. So now you realize both of these patients need water. Both of these patients, in fact, should have their volume deficit corrected within a few hours, because there is no advantage to a patient to remain volume depleted. But on the other hand, the tonicity change, if it happened rapidly and the brain didn't adapt, you could reverse it rapidly. But if it happens slowly and the brain has adapted, it would be deadly, it would be lethal to change the tonicity rapidly. So let me tell you how we're going to proceed. In vignette 42, the lady lost about 5 liters of water in a few hours. Her brain is not functioning. We could give her the same amount of water in a few hours. And the way to do that would be D5W. Dextrose 5% in water, infused over a period of a few hours. That would revert her to normal. If you did that to the patient on vignette 43, he would die, because his brain adapted over 5 days to a tonicity change. It cannot be pushed back in a few hours to the way it used to be. So how can we, on vignette number 43, give the patient the volume that's needed without changing the tonicity too quickly. We don't use D5W. We use an IV fluid that contains more water than salt in relation to what the blood has, but not to the degree of D5W, which is pure water and sugar. So you give this patient 5 liters over the next several hours of D5 1/2 normal saline. And this will enable you to replenish the volume fairly quickly, but change the tonicity gradually, because you have not given this patient 5 liters of pure water in the veins in a few hours, which would have been deadly. You give him 5 liters of a sodium-containing solution that has a little extra water, D5 1/2% saline, and that changes the volume rapidly, but changes the tonicity safely and slowly. Let us move to the next. We're now on vignette number 44. And this is a repeat. We had read this one. 12 hours after completion of abdominal hysterectomy, a 42-year-old woman becomes confused and lethargic, complains of severe headache, has a grand mal seizure, and finally goes into coma. Review of the chart reveals that an order for D5W to running at 125 ml an hour was mistakenly implemented as 525. Her serum sodium concentration is 122. Let's now ask ourselves the same question we asked ourselves a little while ago. When you read on an exam question that the serum sodium concentration is 122 instead of a normal 140, what does that mean? Well, usually it doesn't mean the patient has lost sodium, quote unquote. It usually means the patient has retained water. And in this case, it's obvious how it happened. A lot of water is given intravenously. There was a lot of ADH on board because of being a post-operative period, and the water was retained. And therefore, all the fluids are full of water. The whole body is diluted. This is reflected in the serum sodium, and because it happened in a few hours, the brain hasn't had a chance to adapt. She is in coma. This, therefore, could be reversed in a few hours. And this is one of a few examples in clinical practice where we would feel justified in using hypertonic saline. 3% or 5% saline. Now, we don't order that and come back and see the patient the next day. You use very small amount. The aliquot for 5% sodium concentration would be 100 cc's at a time. The aliquot you would use for 3% saline would be about 500 cc's at a time. And you reevaluate the situation. By the way, normal saline, to give you an idea what these numbers mean, normal saline is 0.9% salt solution. So we're talking about fluids that are 3 times as concentrated or 5 times as concentrated as normal saline. So that would be the therapy. I have to add that this is a situation of very high mortality. It's terrible when this happens to a young lady because they often die. But your answer on the exam would be either the 3% saline or the 5% saline. But now I'm going to read you another vignette where you realize the situation is very different, even though the numbers from the lab look the same. This is vignette 45. A 62-year-old woman comes in for her scheduled chemotherapy administration for metastatic cancer of the breast. Although she is quite asymptomatic, the lab reports that her serum sodium concentration is 122. Now, you know that cancers can sometimes make hormones. What we have here is an example of a patient whose disseminated breast cancer is making ADA just a little bit, but sufficient for her to gradually, very slowly retain water. That's why her serum sodium is 122, because she has retained water. But because this happens so slowly, her brain has adapted to it. You would not want to give this lady hypertonic saline. In fact, the safest thing to do in this lady would be simply water restriction. You instruct her to drink less water every day so that she doesn't retain as much water. Let me move to another one that represents a different way that this problem could happen. A 68-year-old woman comes in with an obvious incarcerated umbilical hernia. She has gross abdominal distension, is clinically dehydrated, and reports persistent fecaloid vomiting for the past 5 days. She's awake and alert, and her serum sodium concentration is 118. Why is she awake and alert even though she's got this electrolyte abnormality? You know already, because this happened over 5 days as opposed to 5 hours. Now, how did this happen? She's been losing GI tract fluids, vomiting them, trapping them in the lumen of the gut. And GI tract fluids happen to be isotonic with plasma. So at the beginning of her problem, she was losing extracellular fluid volume out of her circulating space into the lumen of the gut or vomiting. But at first, there was only the volume deficit with no tonicity change, because she's losing isotonic fluids that are left behind have the same tonicity. But eventually she gets very thirsty. If she had gone to medical school and she knew that the fluid she's been losing contains sodium and bicarbonate and chloride and so on, she would have been drinking a proper electrolyte mixture to replace what she lost. But she doesn't know that. What a patient typically drinks when they are thirsty is water or tea or Coke, things that do not have sodium. So she has been losing isotonic fluids and taking in as a replacement essentially pure water. The body is so desperate for the volume that is missing that the body retains that. So we have overall volume deficit. At the same time, we have water retention. And we have, therefore, the electrolyte pattern that we have read. And the best way to manage this problem would be to give the patient isotonic fluids. That's what she lost in the first place. The specific isotonic fluid would depend on her acid-base balance. If she is rather acidotic, you want to give her Ringer's lactate. If she's rather alkalotic, you want to give her normal saline. But she doesn't need hypertonic fluids. She needs over a few days to replenish her volume, and then she will on her own get rid of the extra water that she had retained. I'm going to digress now here for a second before we move into the next vignettes that have to do with potassium, because I want to repeat some of these. We're going to cut away from my face and go to a little decision tree on the screen. Let me repeat. These are things that we already talked about with the vignette. You read an exam question, you realize there is a high serum sodium concentration. The number you are giving is higher than 140. What does that mean? That means a patient has lost water. Roughly 1 liter for every 3 milliequivalents above the normal value. And that in turn tells you that the treatment, if the change happened quickly, like a few hours and the brain is not functioning, you could replace it with D5W. You lost water quickly, we give you water quickly. But on the other hand, very important, remember the man that was locked in the metal truck. If the change happens slowly, over days, and the brain is functioning, replacement with D5W would be lethal. You might remember, by the way, that people who died from this therapeutic mistake would have that myelopontine degeneration. That's a pathological finding when an autopsy is done. You want to use, in this case, D5 half normal saline, a fluid that contains sufficient sodium to slow the change in the tonicity. Now, what about the opposite? Low serum sodium concentration. You read an exam question and you find that the value for serum sodium is lower than 140. That means the patient has retained water. And for that to happen, it means there is an abnormally high ADH. Because if you simply took a lot of water, you would eliminate that via the kidneys. So now how do we treat that? Well, if it happened quickly, there is no brain function, what we call water intoxication, you should very carefully use hypertonic saline, either 3% or 5%. But if it happens slowly over days, the brain is functioning. Then if you have protracted gastrointestinal loss and the patient looks dehydrated, you use isotonic fluids like normal saline if the patient is alkalotic, or Ringer's lactate if the patient is acidotic. But on the other hand, if it happened very slowly over weeks or months, the brain is functioning fine, there is no history of fluid loss, and you realize this is very slow water retention. The example we had used was a lady with a breast cancer. Then you realize that your best therapy would be water restriction, the safest way to proceed. We're going to move now to vignettes. Again, now dealing with potassium. Let me read now vignette number 47. A patient with severe diabetic ketoacidosis comes in with profound dehydration and a serum potassium concentration of 5.2 milliequivalents per liter. After several hours of vigorous therapy with insulin and IV fluids, saline without potassium, the serum potassium concentration is reported as 2.9. What happened here? When a patient has acidosis, as this patient had, it means there is too much hydrogen in the blood. One way to survive is to put some of that hydrogen into the cells in exchange for potassium. So a patient who's being acidotic for 5 days, a lot of potassium has been coming out of the cells into the blood to make room for hydrogen that was stashed away into the cells. But when that potassium reaches the blood and elevates the potassium level in the blood, the kidneys eliminate that potassium because the kidneys are not aware of the fact that this is potassium that belongs to the cells and eventually will have to be given back. The kidney simply sees high level of potassium in the blood. The kidney does his duty and eliminates the potassium. So this happens for 5 days. When that patient comes in, the serum potassium concentration is still high because he's still acidotic. But then as the treatment begins, the acidosis is corrected. All of a sudden, you don't have an excess of hydrogen in the blood. The hydrogen then comes out of the cells, and the cells say, give me my potassium back. But that potassium is in the toilet. The patient has been urinating that potassium for several days. Well, the cells take it anyway. And so a profound hypokalemia develops very quickly. And that's why you might remember that in the treatment of diabetic ketoacidosis, as soon as you're rehydrating the patient and urinary output has been reestablished, you are asked always start potassium administration. And it's one of the examples where we can use even the rates of potassium administration that normally we don't dare use. You know, the safe limit of intravenous potassium administration, the number above which you're not likely, below which you're not likely to get into trouble, is up to 10 milliequivalents per hour. In this case, you could give perhaps even 20 milliequivalents per hour. So the answer in this vignette then is the patient needs potassium administration, perhaps as quickly as 20 milliequivalents per hour during a few hours. Now we move to vignette number 48. An 18-year-old woman slips and falls under a bus and her right leg is crushed. On arrival at the ER, she's hypotensive and she receives several units of blood. Over the next several hours, she's in and out of hypovolemic shock and she develops acidosis. Her serum potassium concentration, which was 4.8 at the time of admission, is reported to be 6.1 a few hours later. Now, how did this happen? Obviously, her kidneys cannot eliminate it as quickly as it's coming in, but where is it coming from? Well, let's review it again. Her leg was crushed by a bus. What comes out of cells when they get crushed? Intracellular components, including potassium. Then she gets a lot of blood in the hospital and blood in the blood bank. If it's been there for a few weeks, has a high serum potassium as the red cells die and free that potassium. There's another source. Then she's in and out of hypovolemic shock. She doesn't have enough perfusion and she develops acidosis. What happens to potassium in acidosis? It comes from the cells to make room for hydrogen. So we have all of these things that are adding potassium to her blood and her kidneys cannot keep up with it. Well, the ultimate answer for this lady, of course, is hemodialysis. But hemodialysis is typically not instantly available when you need it. It may take a few hours to get the opportunity to hemodialyze a lady. What do we do in the meantime? We can use other ways to lower serum potassium. Exchange resins like Electrolytes, nasogastric suction. But the most effective thing to protect this lady, in fact, would be to give her calcium. Calcium isn't going to change her potassium concentration, but you're worried about what that potassium will do to the myocardium. You're worried that that high potassium concentration will lead to cardiac arrest. You can counteract that with calcium. I'm now going to read vignette number 49. An elderly, alcoholic, diabetic man with marginal renal function sustains multiple trauma while driving under the influence of alcohol. In the course of his resuscitation and multiple surgeries, he is in and out of shock for prolonged periods of time. Blood gases show a pH of 7.1, a pCO2 of 36. His serum electrolytes are sodium 138, chloride 98, and bicarbonate 15. Let me suggest a strategy on how to look at a vignette like this. When you realize in a vignette that an abnormal pH is given to you, in this case a pH of 7.1, I want you to immediately think, is that indicative of acidosis or alkalosis? And of course 7.1 is acidosis. It's below the normal of 7.4. And then I want you to immediately look at the pCO2 to see if you could blame the lungs for the problem. And the next value, in fact, right after that pH is a pCO2 of 36. The normal is 40. If the problem were the responsibility of the lungs, it would be higher than 40 on the pCO2. You find that it is 36, in fact lower than 40. The answer is don't blame the lungs. This is not respiratory acidosis. The lungs are getting rid of the carbonic acid. So it must be metabolic acidosis, which you confirm because you read next that his sodium is 138, chloride 98, and bicarbonate 15. The normal bicarbonate is about 25. So that you have the bicarbonate deficit that we typically see in metabolic acidosis. So the diagnosis here is this is metabolic acidosis. But in order to come up with a management, you ought to figure out why is it happening. Because if you simply play chemist and add bicarbonate to the blood of a patient who's acidotic, you can change the pH, but it might not be the best thing to do for the patient. So it's best when you have metabolic acidosis to figure out why is it happening. And it's obvious when you read this vignette that the problem is insufficient perfusion of the tissues. he is in and out of shock for prolonged periods of time, and that leads to acidosis. And so the therapy for this man is to correct that fluid deficit that he has that leads to shock for prolonged periods of time. Now, the fluid you give him should be one that doesn't make acidosis worse, but one that actually improves it a little bit. So rather than giving him a lot of saline, which would not be the best choice, give him plenty of Ringer's lactate. If you give this man plenty of Ringer's lactate, he will perfuse better, and that will correct the acidosis. Let's move to the next one, vignette 50. A patient who's had a subtotal gastrectomy for cancer with a Billroth 2 reconstruction develops a blowout of the duodenal stump and a subsequent duodenal fistula. For the past 10 days, he's been draining 750 to 1500 ml per day of green fluid. His serum electrolytes show a sodium of 132, chloride of 104, bicarbonate of 15. The pH in his blood is 7.2 with a PCO2 of 35. Let's use the same analysis here. pH is 7.2. Does that mean acidosis or alkalosis? It's acidosis. Well, should we blame the lungs? Let's look at the PCO2. PCO2 is 35. PCO2 is not higher than 40. Don't blame the lungs. This is again an example of metabolic acidosis, confirmed by the fact that his bicarbonate was 15 instead of 24 or 25, the normal values. What do we do when we realize on an exam question that the problem is metabolic acidosis? Figure out why is it happening, because that directs your therapy. Well, what is happening in this man? He is leaking out fluid from the duodenum, green fluid. What makes that fluid green? Bile. What is bile famous for in its electrolyte composition? That has tons of bicarbonate. What comes right along with the bile through the same little Y arrangement in the second portion of the duodenum? Pancreatic juice, famous for being loaded with bicarbonate. So what has led to metabolic acidosis in this patient? Protracted loss of bicarbonate. So if you give this patient bicarbonate, you would be doing the right thing. You would not just be playing chemist and playing with the pH. You would replace what he needs. And bicarbonate can be given as bicarbonate. It comes in ampules of 40 milliequivalents you could add to the IV fluid, or as a precursor that the body makes into bicarbonate, acetate or lactate. So this man needs either sodium bicarbonate, sodium lactate, or sodium acetate. Either one of those would be the correct answer. And the third vignette, dealing with an acid-base problem, is so classical that it doesn't even come with a pH. A patient with severe peptic ulcer disease develops pyloric obstruction and has protracted vomiting of clear gastric contents. By clear, I mean without bile, pure gastric juice, for several days. The serum electrolytes show sodium of 134, chloride of 82, potassium of 2.9, and bicarbonate of 34. This is such a classical pattern. Hypochloremic, hypokalemic metabolic alkalosis that he doesn't even need a pH to be given. The alkalosis is reflected by the high bicarbonate level, and you realize that the potassium and the chloride are both a lot lower than they should be. And this is what we see when a lot of acid gastric juice is being lost, which this patient has had. And we can treat most of these with a generous administration of potassium chloride. That corrects the whole problem. And let me repeat the safe limit of administration. As long as you do not exceed 10 milliequivalents an hour of potassium in the veins, you're not likely to kill the patient. And if you gave 10 milliequivalents an hour, that would add up to 240 milliequivalents a day. That's plenty of potassium, because you and I normally eat around 75 milliequivalents a day. And in fact, the patient with mild metabolic alkalosis could be treated with potassium infusion at a rate of about 5 milliequivalents an hour, which add up to 120 in the whole day. So anywhere between 5 and 10 milliequivalents of potassium per hour infused into the patient would be the appropriate treatment for metabolic alkalosis. Now, I'm going to repeat this in the form of one of those decision trees. We're going to cut away from my face. We're going to go to the words on the screen. So we read an exam question that shows an abnormal blood pH, which could also be expressed as abnormal nanoequivalents of hydrogen per liter. If what we read is a pH is lower than 7.4, or the nanoequivalents of hydrogen exceed the normal value of 40, the diagnosis is acidosis. We then want to look at the PCO2. If the PCO2 is equal to or lower than 40, which is the normal value, don't blame the lungs. It is metabolic acidosis. Figure out the cause and treat it. Do not just play chemist, okay? But if we have a pH that is above 7.4 and the nanoequivalents of hydrogen are less than 40, that means the patient has alkalosis. Well, you look at the PCO2 again. If it is equal to or greater than 40, don't blame the lungs. The lungs are not hyperventilating and producing the problem. It is metabolic alkalosis, and you treat that in most cases quite successfully by providing the patient plenty of potassium chloride, namely 5 to 10 milliequivalents an hour. Let me continue. If you have acidosis with a high PCO2 or alkalosis with a low PCO2, then there is a respiratory problem. Now we should be blaming the lungs. If the numbers of the PCO2 and the nanoequivalents of hydrogen per liter are roughly the same, the acid-base problem is purely respiratory. And we treat by increasing ventilation if there is respiratory acidosis, or by decreasing ventilation if there is respiratory alkalosis. And that takes us to the end of postoperative complications.